So reproductive psychiatry is one of the subspecialties of psychiatry, which is a specialty of medicine. And the focus is really treatment of psychiatric disorders in the perinatal period. So anywhere from, just trying to conceive, trying to see what options there are, to throughout the reproductive cycle. So first child, second child, all of those kinds of changes that someone might go through in their life. Reproductive psychiatrists are there to kind of help treat whatever mental illnesses or stressors they could be working on. I want to say that medication is absolutely safe to use during pregnancy, safe to use during breastfeeding. That's kind of a short answer to your question. Um, but, I think that there is a lot of concern that a lot of people have during pregnancy, postpartum, breastfeeding about, well, if I'm taking something into my body, is it going to impact the baby? Is it going to impact me? And really, it's a conversation with the patient and their doctor about their needs. I think sometimes we don't always take into account that, you know, mom's mental health needs or, the parents' mental health needs are very important. And also, untreated illness can have an impact on the baby that people don't always take into consideration as much as, wait, there's a pill that could also impact the baby. There's also illness that can impact the baby, and mom too. I mean, I feel like it's always what's the impact on baby, but also mom is important, or the gestational parent is important. Um, and so it's a conversation with patients. And for me, I like it to be a back and forth, really letting her know what her options are, what some of the safety risks are, both with and without medication, and then us kind of coming to a plan that makes sense for her needs at that time.
For both mom and baby.
Yeah, yeah. Great question. Yes, there are risks of not taking medication. Some of them are, and I think some people might understand this piece, but if mom isn't doing well mentally, it makes it harder to go to prenatal appointments, makes it harder to kind of take care of herself and the baby. And that's certainly one large aspect of it. But also, with untreated mental illness, there are increased stress hormones in the body of the mother or the gestating parent that can actually get to the baby. And we can see physiological differences too. Not that, difficulty getting to appointments and all those things aren't important, but also it has an impact on, preterm delivery, baby being low weight for their gestational age. And then some of the other risks for preterm delivery would be maybe a NICU stay. Preeclampsia is another risk. So there are also physiological effects in addition to some of the more psychological effects as well. I was a breastfeeding mother. I breastfed both of my children. I understand, and for such a long time in this country, especially, there was almost a stigma against breastfeeding. It was seen as gross and somehow sexual, even though this is, literally what the organ is. And I think the breastfeeding culture came out of a place of really wanting to encourage women in a culture that was not encouraging and sometimes, discouraging of breastfeeding. Um, but at the same time, some of these groups, in their effort to be encouraging, can really create an environment where this is the only way. And a lot of times women can feel there's something wrong with them if it's not working or if maybe they don't want to do it. And, we have an abundance of ways to feed babies in this country. And I think sometimes that isn't always acknowledged. And, you know, I and because it's something so intimate and so personal, it can be another thing that really weighs new moms down. Like, I don't really want to do this, or I can't do this, or it's really difficult to do this. And it doesn't need to be that way. formula is just as good as breastfeeding. I remember I saw a picture once where it said fed is best, and it had one woman nursing the baby on the breast, another woman with a bottle, and another woman connecting food into a baby's G tube. You know, whatever way your baby needs to eat is fine, and we don't the amount of pressure put on women to breastfeed. I think it's almost like an overshoot of the movement, if that makes sense. I think so. The best parts of our day program, or the most magical parts, because sometimes this place does feel like magic. Um, I think the group therapy is great because you're getting the benefit of having a therapist there, but also peer support. So it's kind of the best of both worlds. A lot of these moms start friendships in this program, feel not alone for the first time in their struggles. I think the fact that we do dyadic work, so mom and baby therapy, is huge. And I wish everybody could do some dyadic work with their baby because it can really help you mentalize your baby. So basically understanding things maybe from their perspective, or how they're growing and starting to understand you and their relationship, and then vice versa. Taking a close look at your own childhood and how you were parented, and maybe how you would want to do things differently. I think our program really helps a lot of people in that aspect. And then, of course, having individual therapy multiple times a week, and seeing a psychiatrist at least once a week, which is like so rare. I think those are part of the things that make this place magic. So, I come against, women who may benefit from our day program, and there is some pushback initially. And, oftentimes I'll try to explore with them what the pushback is. I think to what you said about, well, I'm not sick enough. A lot of people struggle with, do I deserve kind of time to myself? Another big thing is, it's just going to take time. And sometimes what I like to get them to realize is, yes, it takes time. It's 5 hours a day, often for 6 weeks, but it helps you get time back. It helps you feel like you're getting your life back. And so doing something so intensive, where you can also bring your baby to, by the way, so you can still have that bond with them most of the day, but really taking the time to focus on you and be a better version of yourself for your child, it actually gives you more time back, rather than really struggling for months on end, maybe years, to kind of feel back to where you need to be. The women who come into this program, like, oftentimes they're coming at a very, very low point in their life, and they go through a lot of changes. And I think that it's that the first week is typically the hardest, and I try to tell patients that. A lot of patients actually initially kind of want to leave. They're either feeling they're not sick enough, or they're skeptical that it may not be helpful. And in fact, I just did a goodbye session with a patient this morning who we kind of laughed about her skepticism and how she kind of pushed against me, and how I encouraged her to do so, to really figure out what it was she needed. And, I think what was great about her is just to see her blossom over the last 2 months, seeing more of her personality, seeing her kind of relax a bit, and really just be present with her children, with her husband, and kind of just feel comfortable coming into her own as a mother. Yes. One of the great things about working at the Motherhood Center that I've seen is that from the time of them calling and getting screened, we get them in quickly. I'll sometimes see evals come into my calendar for next day, or the next couple of days, and that's great because I know it can be so hard to get a psychiatrist. Sometimes people are in months-long waiting lists, and here that's really not the case, and that's important, right? Because this is such an acute time in someone's life. Like if they're pregnant, we want to help them now. If they're postpartum, we want to help them now. And the fact that we're able to see people quickly is wonderful. So women of color, and specifically Black women, often have higher rates of maternal mental illness. And I think, I mean, if I'm being honest, probably the biggest reason is racism. And what I mean by that is, systems that make it really difficult for women of color to access health care, first of all. Systems that, train providers to maybe make assumptions, such as, there's studies that say that some providers have this bias that, Black people or people of color have higher tolerances for pain, things like that. Systems where, it's not as common to have a diverse array of people in the field, especially medicine. So the cultural awareness is not kind of permeated through, medical training and all of those things. I think also, not only with the issues with healthcare, but then, those issues are compounded by, Black women are more likely to face food insecurity, are more likely to face discrimination, harassment, those kinds of things, and that adds up. And then also, maybe their OBs may not see that they're in pain, may not see that they're in emotional pain as easily as they would a patient who maybe is of another race or ethnicity. And so all of those things kind of unfortunately add up and come out in these statistics where we're seeing women of color are more likely to have a PMAD. And it's a multi-pronged problem that will take multiple different ways to kind of address. So, evaluation of the PMAD is first and foremost. Their OB or whoever is seeing them needs to also acknowledge that they have a PMAD and see that in them. Certain things like anxiety may be read as anger or something like that, and if it's not read correctly, then they're never going to even get the referral. The fact that it's hard to get into mental health care in general, not to mention reproductive psychiatry. So there are wait times that are very long in a lot of ways. Costs, whether health insurance is going to cover mental health care, whether or not you can pay out of pocket. So those are also some of the things that impact access. But I would say the biggest thing is, first, your provider needs to know that you're struggling. Yeah, so what providers can do to kind of really address this problem of, perinatal mental health is to, first of all, remember that, mom is a person who has the whole breadth of human experience. And so, she can struggle, even though, yes, maybe having a baby is the happiest time in her life, it may not be. Knowing that, it's more than just, oh, well, it's just the baby blues, you'll get past it. Acknowledging that mom is a person who has needs, and needs that are just as important, if not more important, than the baby she's carrying or the baby she just birthed. I think it's really easy to forget that. I think I heard a while ago here when I was doing my array rotation as a resident, that oftentimes people treat the baby like candy and mom is the wrapper. And mom is a full human person who has needs that are important. It's not just about the baby.
Excellent. And what would you tell a provider who, because they lack awareness or confidence in managing medication throughout the perinatal period, who is more comfortable advising their patient to stop medication altogether, which we see a lot, and understand, and also understand the risk to that. What do you want providers to know, or what should they do if they don't feel confident in this area of medication and pregnancy?
Yeah, I mean, first and foremost, for providers who feel uncomfortable with patients who come to them with psychiatric medications in their regimen, first and foremost, I would tell them, do not stop the medication until you speak to a reproductive psychiatrist. It is so important to make sure that mom is mentally stable. And if you have a patient who suddenly finds they're pregnant, the baby has already been exposed. So it is okay to take your time to make a decision. If it's something that might need to be switched, then that's a conversation to have. But to stop all the medication altogether can do a lot of harm. And I don't think enough providers think of it that way. You know, having a baby is wonderful and beautiful, but you're deserving too. And your needs are important, and your health is important.